Right. So this is the session from Germany, from computer vision to parental satisfaction contributions from Germany. And we have already had a short introduction video, and now I'm here with you all, and we want to start with the first pitch about computer vision and machine learning in early infancy, and what are the pitfalls of a broad screening of CP, for example. So let's just go straight ahead and talk about general movements. General movements were described for the first time in the 70s or 80s in the group of Groningen. Professor Heinz Prechtel found out or wrote for the first time that the quality of spontaneous, and that is self-generated movements in early infancy or the fetus, accurately reflect the condition of the nervous system and the central nervous system. And that this is especially true for the quality of general movements, so to say. And for this, he started to do video recordings of infants and started to rate them. And for that, they took 3 minutes of videos of 2D RGB videos, and recorded the spontaneous activity of the infants at the intensive care unit or even at follow-up in the well baby clinic. And general movements are whole body movements that already appear in the 7th week of post-menstrual age. And these typical general movements take part in all body parts, and they are typically characterized particularly by movement complexity and variation. And movement complexity is refers to the spatial variation of movements. That means across the room, the left arm, the left leg, and the other body part, so independently from each other, across the room surrounding the infant. And the variation of movements is referring to the temporal variation. That means across the 3 minutes of video recording, the infant is moving more or less constantly, but having little breaks, intensifying movements or slowing down with movements. So the temporal variation is something that is tightly connected to the general movement complexity. And in total, this refers to the Gestalt perception. So rating general movements means that we have to take into account the whole body movements across time. And so this is called the Gestalt perception. So what you do is you do a 3-minute video recording, and then after this video recording, you watch at the video and you rate the movements of the infants. And what you see, as I was talking here, on the left side, you see an infant now corrected age of 12 weeks of gestation, showing complex and variable spontaneous activity or general movements. This is involuntary, of course. And on the right side, you see an infant who does not show this complexity and variation of movements, but is very poor in repertoire. And this is an atypical or definitely abnormal general movement. So to summarize this one more time, the atypical GMs are manifested in impairments in quantity and quality of these general movements. And that means that there is a marked reduction in movement complexity and variation, which is called a poor repertoire, but also a failure to develop age-specific movements. And this is specifically addressing the presence of fidgety movements. And you will see this later in the other video, because fidgety movements are tiny superimposed movements on the broad amplitude general movements, which really represent the transition phase into the voluntary movement development as the brain matures. Atypical GMs that combine poor repertoire and the absence of fidgety movements reflect a serious impairment of brain integrity. And by this, they have a high predictive value for the detection of cerebral palsy. And this is what makes this biological principle of general movements really interesting for the early detection, especially for children with cerebral palsy. The sensitivity and specificity for other diagnoses like autism spectrum disorder or attention deficit and hyperactivity disorders is also possible to detect this with the general movement analysis or the assessment of general movements, but sensitivity and specificity of this is definitely much lower than for the early detection of cerebral palsy or the risk for later on developing cerebral palsy. So what we have done, and especially Nicolas, who is with us today, Nicolas Hesse has done since 2015, is to develop digitized 3D full body infant model, the skinned multi-infant linear body model, or the SMIL model, how we often call it. And this is a lot of post-processing, but in the first recording step, it's not that complicated because we have commercially available 3D camera that is connected with a, well, not really simple, but commercially available notebook. And just by recording 2D data and 3D point cloud data with the 3D camera on a laptop, we can then do the post-processing. That means that we have an infant body model, a SMIL model, which is then frame by frame registered with the point cloud surface of the infant. So frame by frame, this body volume of an infant is fitted underneath this surface mesh. And by that, we develop a digital full body model of spontaneous activity of the infant. And with this digital full body model, we can then go on and put it into further analysis. Just to give you an insight of Gestalt perception and the data input that we can use for the machine learning algorithms that we want to develop. Here you see again a child with definitely abnormal general movements in contrast to a child who has more normal general movements. So you can already see that the input data really simplified here by these 9 points of the joints and the extremities give us some insight into the movement complexity and variation and the quality of movement which we use for input in machine learning. So as of now, we are trying to develop machine learning algorithms which are supervised. So we tell the machine to look for things that resemble movement complexity. And then on the second track, we try to extract data and information, motion information from video sequences that represent the variation of time. And if this is very complex and this is very complex, at the end, this support vector machine tells us that the infant is doing a good job with these general movements and giving us a green traffic light. And if both of those are, let's say, not normal, then we come up with the conclusion that this infant has a high risk of cerebral palsy. And where both of them are not telling us the same result, then we have a controversial result, and this is referred to a human expert. And with this paradigm, we have looked already in more than 100 infants, I think 124 infants, and could detect all infants who had a cerebral palsy later on, but also another child with not cerebral palsy, but another developmental disorder. And so sensitivity and specificity with this supervised machine learning algorithm was quite encouraging. We can also use the motion data that we are capturing to look at other parameters that could be interesting for science. So we could look for asymmetry indices, we could look for joint angles, and joint positions. We could look at distance traveled against gravity or across time in the whole volume around the infant, and many other things that we can look at. So this is still, of course, things to be developed, but this is where we are looking for at the moment. So in summary already, we can say that, of course, early prediction of long-term neurodevelopmental outcome remains challenging. That is for sure, and we can discuss about this later why. but there seems to be a chance to use technical innovation to minimize, for example, the human error in the early detection part in the general movement analysis or the assessment of general movements. And we can maybe use this approach to develop reliable screening tools that can be applied in the broad screening of the normal population. But we can also use the data to look for any other objective outcome measure regarding motion when we want to, for example, assess interventions in early infancy or just track development across time. So with this summary, in the end, I want to thank you and everybody who has already contributed to this project with this wonderful view on the ancient monastery in Maulbronn, which is a World Heritage. And looking on the past, we can now maybe look a little bit into the future and discuss things that can happen, hopefully, and will be possible to develop with the two experts that I have with me here. Meiner Hadas-Aigra, developmental neurologist and expert in the field of early detection and also early intervention, and with Nicolas Hesse, who is the developer of the SMIL model and also, of course, an expert in computer vision, machine learning, in motion tracking, in human motion tracking. And so, Meiner, maybe you can start and tell us a little bit about your thoughts of why at all we should have something like a screening in the broad population, or maybe also what is the risk of doing so?
Yeah, thank you very much, Sebastian. I think we learned from studies in high-risk populations, especially populations of preterm infants, that general movement assessment carried out by expert has a really high predictive value for especially CP, as you already mentioned. But we also know that learning this technique takes a large amount of experience, which makes it hard to use it in the general population. And I think time has really come now that we can learn the machines to do it. So I hope really in the near future that the machine learning can be applied just in the whole infant population. And we know, we only have very few studies, we know already that the predictive value is then a little bit lower. It is lower because in the high-risk populations, usually the lesions are in the periventricular white matter, and lesions in the periventricular white matter really affect the quality of general movement, so hence the good predictive value there. We know that in the general population, we also have children who have other lesions, other places in the brain, and that reduces to some extent, not very much, but to some extent predictive value. But nevertheless, I think if you have an infant, whatever infant, showing at around 3 months of age, 2 to 4 months of age, corrected age, definitely abnormal movements, it means that this infant is anyway in need of early intervention. So actually we don't have false positives. Perhaps the child will not end up with a cerebral palsy, but the child needs intervention. So I think it would be super if we could implement this in the general infant population. So actually I don't see risks. The only risk perhaps one could mention is that it needs to be implemented, and that costs money. Mm-hmm. But on the long run, I think it pays back, because if you catch the infants early and you can guide infant and family early, outcome of both family and infant are better. And so there we get a cost reduction in healthcare.
Okay. All right. I think when I started to think about this concern, what concerned me was really the possibility of having false positive results. And I think it's encouraging if you say that you would not see this as a major limitation. I think the most important thing is, as always, if you want to develop a new methodology that you have to be sure that it is carefully applied. It's not that just by putting somebody underneath the kinemat or the SMIL modeling analysis, then and you come up with a traffic light which is red or yellow, then it's time to scare the families. Definitely that's not what we are intending to do so. And therefore it's just the way how later on this setting will be communicated with families and parents, and especially before that with the doctors that we want them to use the system, so that everybody is reflective on what they're doing.
Yeah.
With results.
Yeah. Yeah, I would like to add there, indeed, if there's a red light, so to say, then it is how do you communicate it to families, very important. And of course, you need then to seek out and what's the cause of why is the infant moving like that? So you have to elucidate that. Mm-hmm. And then the other part is the guidance of family. So you always have those two things you have to keep in mind. And so with prediction, I think the prediction, so the false positives, I won't say there are no false positives, all children are in need. So, but we have to bear in mind that we also miss infants. Yep. Because of that some lesions don't result in definitely abnormal movements or even mildly abnormal movements, and still the child will have ACP.
So that means
when the light is green, it doesn't mean that you will never end up with CP.
Yes. So you are more afraid of the false negative than of the false positive.
Yeah.
I think one of the chances is with such a clinical tool, if it would be applied, it gives the doctor the chance to support his idea of why he should give therapy or not, and maybe come to this conclusion with an optimal state of the infant. So if a child is, for instance, sick at the doctor's appointment or crying, he cannot have a good impression on the developmental level of the infant. But if family comes back maybe 15 minutes later and the physician is already doing something else, maybe then the algorithm could make a better quality analysis with instead of a crying infant in the doctoral examination. So this is also another good part of some sort of automated detection, that this relieves a little bit of the burden of workload of the doctors, not making them superfluous, but supporting their decision making on a qualitative good data basis. Yeah. Nicholas, what do you think? I mean, everybody is talking about machine learning, everybody is talking about big data, and everybody's looking for experts like you are. And so you could probably, hopefully tell us a little bit about your ideas. Why do you think this is something that will be reliable, or what do you think are the risks of such a system, or maybe even just also the boundaries of what will be possible with something like this?
Yes, thank you. So I really think the important part is, that it's not a black box that just outputs a score and then based on this, the next steps are planned, but we really need the system to kind of explain how it got to the decision so that the doctors can really see how the decision was formed. Mm-hmm. And well, for that, I mean, the first step is to accurately capture the motions, because that's what we base the decision on. Mm-hmm. And I mean, in our system, we use the 3D cameras just because we really believe having the most accurate and most detailed kind of data will help us make better decisions in the end, like having 3D joint positions and angles instead of 2D. There's just more information about the real motions. And for the second part, in the machine learning, we really want to have a detailed output and like in the one slide you showed, we kind of want to have a confidence value. How much can we really trust this? I mean, there will be examples where it might be obvious also for like an untrained observer that there's something that the GM quality is low. but especially in the kind of the gray areas, it's not so easy. So there we need to say, okay, we believe this is the GM quality, but in some cases we need to investigate closer.
Mhm. And do you think that can you say, or could one say that the 3D data that is captured with this approach, in contrast to the 2D data, supplies us with a better ground truth of data to work on with machine learning? Or how would you ground truth is another one of these buzzwords that's around there all the time at the moment.
I mean, it's hard to say if we really need this kind of detailed data. It could be that 2D is enough and it's perfectly fine. But since we don't know already, I think in my personal opinion, it's better to kind of try to get the maximum quality of motion capturing and then try to work on this and see maybe later if we can relax these constraints and maybe just to use 2D cameras.
Okay. Well, thank you very much for your thoughts. I think we have to keep on going with the other sessions, so we can stop here and go back into the live session then. And thank you very much for your thoughts and your time sharing your knowledge with us at the moment.
Thank you.
Bye-bye.
Bye-bye.
Over to Rainer, and
Yes.
he will take over the second part. Thank you very much.
Great, indeed. So I hope you see my presentation. Hello, everybody, to you. And yes, it's a pity that we missed now the presentation from Sebastian on the web. So we start with feeding disorders, in eating disorders, actually in a spectrum of children with disability, of course, also with CP. And I just want to share some data of a survey with parents having had children with an inpatient treatment some years ago because of severe eating disorders. So eating disorders in early childhood are very frequent in children with developmental delays and with developmental disorders. And as you see in cerebral palsy, it's extremely frequent, and in other developmental disorders, in syndromal disorders, and of course in autism spectrum disorders, and of course in children with history of prematurity. So our aim was to examine the long-term outcome as seen by the caregivers with respect to severe early eating disorders. So in a large spectrum of young children, so we were able to divide into subgroups of different comorbidities, as this has not been done previously in other studies. We only know that comorbidities are influencing the outcome of early eating disorders. So we addressed 256 consecutively treated children, and we sent them a 68 item survey at follow-up. The mean follow-up period was 3.5 years after inpatient treatment. And the themes were the parents should describe fairly precisely the recent food intake behavior also, and respective, and should tell us something about their retrospective satisfaction with the inpatient treatment, the recent family burden with respect to eating problems, as there are any, and of course should tell something about their general parental life satisfaction at this time of the survey. So we got a response finally of 103 caregivers, and we had a dropout analysis and found no structural differences between responders and non-responders. And we had a mean frequency of comorbidities of 5.4 comorbidities. So you could see these children were rather severely handicapped and had quite a lot of problems. So we divided this about on the leading disorders they had, and these subgroups you are seeing, like seeing here, as shown, there were a subgroup with mainly CP children. There was a subgroup with mainly autism, children with autism and other behavioral disorders, severe interaction problems. And there was a group with genetic syndromes with severe developmental delay, but without defined disorders like neurological or behavioral disorders. And then there was a last group with children, mainly preterm born children who had not visible severe developmental delays, but they had still feeding problems. For example, they had a tube since preterm and they didn't get it out because of different reasons. If we compare now the subgroups, you see in the first slide here that still after a long time, the neuro group, as we expect, has still quite a lot of eating problems. And even after more than 3 years later, the children of this group had quite a lot of problems. Actually, also in the other groups, the children had still some problems with age-appropriate eating, but the best group was actually, as expected, the children without severe developmental delays or developmental disorders, and these differences were significant from this group to the other groups. And if you look at the other side, you see a fairly contradictive picture concerning the neuro group. The parents with severely disabled children, so there were often GMFCS 3 to 5 children, they were among the group which was most satisfied actually with the treatment. So they didn't have much success with their eating problems, but obviously something happened that made the parents quite happy even after a long time, and they said, yes, the treatment was successful more than 3 years ago, and we are quite happy with that. And you see that the parents of the children with the behavioral disorders and with the other syndromes, children with the other syndromes, they were fairly dissatisfied with the previous treatment, or let's say they were in the medium range of satisfaction. They were not completely unsatisfied, that would be here, but they were not extremely satisfied. So we can say, if we take all groups, we had more than 50% who were very satisfied and 19% relatively satisfied. That makes about 70% which were satisfied with the previous inpatient treatment, but you see here the distributions of the groups. Now we see another point which is quite in concordance with these first data. You see that the parents reporting from these groups, they report still quite a large or quite a severe burden of disease, that means that their children are still very picky with eating and still making a lot of problems with eating concerning the behavioral group, and let's say in a medium range in the syndromal group. And as you see, still that the burden of disease was about in the mid-range. You see a large variability in the neuro group, but you see also there are quite a lot of parents who experience a fairly low burden of disease concerning the eating. So they had solved something with their children. They had arranged something with that they could manage to some extent. And of course, this was the best group without or with least comorbidities. And if you now look on the right side, that is something fairly astonishing, that that all parents experienced fairly good personal life satisfaction. So they were quite happy with their general situation as a family. If you look here, there is a tendency, of course, in the parents who had children with behavior problems. There were here also quite a large proportion of parents who had really who were quite dissatisfied with their general life. And so we can speculate which parents are this, but it's very tentative to say that these are the parents who had on their own psychological problems. In the summary, we can summarize here caregivers of children with severe comorbid neurological handicaps are surprisingly highly satisfied with previous treatment, even after long-term follow-up, and in spite of low objective changes of the eating disorders. Caregivers of children with considerable psychological problems, mainly autistic children, they were quite dissatisfied with previous treatment, or let's say they were moderately satisfied with previous treatment after long-term follow-up, in spite of much better changes of the eating problems compared with the CP children, for example. And they still experienced a high burden of disease even after years. And certainly caregivers of preterm born children without severe comorbidities, having the best outcome. Also, they had the best age-appropriate eating and the highest treatment satisfaction, as we also expected. So I would like to ask you some openness for discussion. Are these observations consistent with your experiences? Or from your clinical experience, would you say that in parents having children with early behavioral problems, treatment satisfaction is diminished in general? And how would you explain these findings? And for these questions, we've got also some survey, which I think we should start, and you can just, while you are filling in this short survey, you can think about your questions. Don't forget to scroll downwards. Auswahl 1 means yes, and Auswahl 2 means no. So the first is yes, and the second is no. think.
I think we have 5 participants so far.
So,
Now 7, they are coming, a bit more, 8. Let's see if we can get the 10.
the questions are rather complex. I think everybody must think a bit about.
But if we have a 2-digit result number, it's statistically more interesting.
Yes, that would be very good.
Okay, there comes number 10. Okay, great. I think I stop the survey now and show you the results. Looks like a big majority is seeing similar results in their populations. And it stresses.
Fine.
Yeah.
So possibly you might comment on that from your experience, or just you have questions. I would just like you to encourage you. I know that there are a few people here who are quite experienced in this field. So, Margaret.
Yeah. Hello, my name is Margret Ziegler from the Kinderzentrum in Munich. It's similar to the Kinderzentrum in Mausbronn. And this is my psychologist colleague, sorry, Maria Licata. We also see children like you have presented, Blank, and we talk about, we think mainly the parents of children with autism spectrum disorders have to live with the children, and the improvement in these children is very small, and sometimes it also the improvement is in the opposite direction. So it's we think it's hard to handle for these parents with these children. They remain to go not so good in contact, and also in the feeding and eating situation. The children show very small improvement, and I think we should prepare more the parents of these children with this fact that also after an intensive inpatient time, the children have often only a small improvement.
Mm. So it's also to your experience, Margaret, that these children with behavioral disorders and eating disorders are the most difficult group, actually.
Yes, of course. And what we often say is we have to look that the children is nutrition, good ernährt, that they are
nurtured.
Yes, and so we have to give the Nahrungsergänzungsmittel. I don't know how to.
They give a lot of supplements.
Then, and often the children just take one kind of pudding or one kind of I don't know, bread, and so they need the supplements that they have.
Okay. So it's also your experience. And is your experience also possibly you may take off a bit the mask for some, if you for 1 minute perhaps?
Yes.
Because you are easier to understand. Is it also your experience that the parents, even with severely handicapped CP children, they are more happy with the results of the feeding therapy? Also, they have still their tube and their pack.
well, I don't know. We haven't made such an follow-up study with the parents, but we often see when the children come later in our hospital that they have arranged together, that they found together with her and they plan their life in other in other space, so they can better in some way accept the situation in all different parts of the child, like the mobility and also the Teilhabe, the participation, yes.
Yeah, okay. So,
but it's very important also for these disability children that they are in the feeding and eating with the family together, and they have a place on the table, and they should also have the possibility to get some food at the lips, also if they cannot eat a big amount of the food.
Okay, fine. Possibly from our group, Ulrike Geiser, and from those who are carrying through the eating therapy in our hospital, there is also a group here. Possibly you may comment also.
I'm very, 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 very sorry, but I think due to the reason of time, you need to go on. This is the first lesson already from this first German's contribution. We have too much content. So I think just so that Lorenz Kivul does have some time to present his results, we should give him another 18 minutes to go on, and need to come up with another format to keep on discussing this really interesting and important topic for the next time. Thank you very much, Rainer. Sorry on the team at the Kinderzentrum for not being able to continue this discussion. But Lorenz, do you want to go ahead and start with your part of the presentation? Thank you very much.
I'd like to. Can you hear me?
Yes.
Wonderful. So I'm also here, only my third day in Maulbronn, and I did the research mainly in the Schön-Klinik Vogtereuth before, and in LMU Munich together with Sebastian. So many thanks to this institution. And I am going to talk about serious gaming. What is serious gaming? Serious gaming is playing games for serious purposes. And what could it be in cerebral palsy? So in cerebral palsy, we invented serious games to play physical physiotherapy exercises as video games, as you can see here as an example with this girl who controls the avatar with her body, and in this does physiotherapy exercises without even realizing. And they can be fitted to the children, or in this boy who controls this ball through a maze, and by that exercises his trunk control. So how does this work? It works a bit like the technology Sebastian uses for the GMR. It's a 3D camera which captures a point cloud, and an algorithm creates a skeleton model. And this makes it possible to create an avatar which works with medical correctness. This is a lot more accurate than playing with gaming consoles from Nintendo. And the other big difference to Nintendo is that the exercises can be really adjusted to the patient. So as a beginning, the therapist clicks on an avatar and selects which regions should be trained, and selects games which are fitting to the needs of the patient. And then it can be adjusted for sitting or for wheelchair, and the games can be started. And as a first step, special games are played. They're called assessment games. These games measure even further the functions of the body. As an example, you can see here the arm abduction measurement, which is a game by creating a snow angel, and this captures the range of motion, which then in the games sets the games that they are challenging and targeted for the patient. We have here another example. This is more for the a lot better CP patients for lifting the legs. So also this is measured and used to set the games. It can also be used to measure progress from the patients. This usually the first time is all performed in hospital still, or at the therapist. And when all this is gone through the first time, the system is taken home, and then the games are played at home. And we have another assessment here, which I'm going to show you, which is for trunk control. So this is also measured, and here you can read keep shoulders centered or keep hips centered. So the system even recognizes if you make evasive movements, which are not the correct ones, and only measures the ones which are really the ones which we want to measure. As soon we are finished with this, the patient is transferred to a game world where he can move himself and go to the therapeutic games and collect coins, and is motivated and even buy things. So it's a world of its own of therapy games. And this then happens at home. We did a study during Corona where 30 patients played at home. This therapy world was really successful. And to give you an idea how this looks like, is this. So usually the patients only played by themselves, but in the study, they were partly supervised by therapists. And in this video, I'm the example therapist here, and 2 PhD students are like the example patients. And I can then connect remotely to the system and also do again some assessments or start games and adjust the games that they are still completely to the therapy adjusted to the therapy targets and to the patient's needs. So I can do completely therapy and setting from the clinic to the patient's home. Again, here I can measure range of motion. And after I measured all newly, the game is started. So now we have the avatar explaining something, so don't be astonished. And now the game starts. Okay, enough. We did a survey by the patients and parents afterwards, and it was really overwhelming positive. Over 90% would do the therapy again. The feasibility was really good, 9.5 from 10 points. And 70% would really recommend the therapy to other children with movement disorders. And the remaining 30% answered this question with rather yes. There were no patients and parents at all which would not recommend the therapy. We are currently working on the statistics and have also positive functional results. For now, we can say that we have clinically meaningful effect sizes in the GMFM-66 scores. So we can also prove that we really change the function of the children. And I would like to close my presentation with a quote by John Locke, which is, "The greatest art is to make children play everything they are supposed to do or learn." Thank you very much. And yeah, I'm really curious for your questions.
Thank you, Lawrence. Any comments from the audience? Otherwise, we would also have a little survey as an appetizer that we could start, and I will do so. And see what your thoughts are. Okay, do you see this question? It's three questions. So question number one, do you see a need for home-based activity interventions for adolescents with developmental disorders? Yes or no? Or do you think it's not worth the effort to do so? The second question is, do home-based activity interventions require therapeutic supervision, or can we leave the patients alone with that? And then the last question would be, what do you think, how many hours of activity per week should be stimulated via this approach? Should we do it broadly? Should we do it consequently? Should we leave it open to the families? All those things, I think we do not really know very well yet, but it's important to maybe get some feedback here in this group, and also then, of course, further on from the applicants later on. Okay, we are more than 10 answers, so I think I stop right here and show you the results. So everybody agrees that this is useful to do it at home. Nobody is afraid of any computer or screen time distraction or problems for the children. The majority also says that it should be therapeutically supervised, and I think it's a good question then how to, maybe we can discuss this, how frequent this supervision should be. Does anyone has a comment on that or any experience? What works at home? How closely do the children need to be supervised by the interventions? Laura, please.
Yes, hi, sorry, I'm talking again. I missed it. Is this device commercially available?
Yes, it's now commercially available.
Okay, because I recently got in touch with the Holland Bloorview group. Are you aware of their system and programs as well that they devised?
How is it called?
Holland Bloorview in Canada. It's called
No.
Brutal Blast. It's called Brutal Blast. It is also commercially available, and it also uses, it's a cost-effective, a cheap device as well, and then you can download the app, and then the children can actually play using the app. And this one is more about participation and getting, you know, their peers and their siblings to play with them and stuff like this. So it's along the lines of similar, but I mean, they're not probably as accurate with measuring the range. But it looks like it would be great if you could link up with the Holland Bloorview in Canada, the group there as well, because they were looking in how to do for trunk and lower limb.
I think this is that's a very good comment. I think it's always the general question, and we have the same for the computer vision and the general movement analysis. Do we try to be really easy and simple, maybe using a mobile phone or just a 2D video camera, something handy on an app, mobile, very quick to use, or do we want to have high accuracy and very good precision in the computer vision part? And I think the approach that Lorenz is developing and we are also using for our infants is that we want to be as precise as possible, which makes us a lot slower in developing those things. But in the end, we are hoping to get better sensitivity, specificity, accuracy with our assessment results. And I think one of the biggest chances for this GAMO system is also that it can give you active range of motions, something that we never really easily detect in clinical examinations, but can be very important if we want to find out what the patient has for a capacity, or what's the difference between structural contractures and active activation of muscle groups. So I think for the computer vision with three-dimensional data background, I think this can be a big advantage if we are on a three-dimensional, more complex setup. And for the participation gaming, I think, of course, this is a good approach to be quick and easy and interactive. However, Lawrence, maybe you want to comment on the team play.
Yeah, so there is actually also a European research project based in Ukraine, which is also on more, let's say, light technology and participation. So I think it always good to participate, to cooperate. While we see the problem in this more light systems, that it only creates activation, and you can also measure this activation, but it does not really result in targeted function. So I'm doing this research since 2016, and then we did some first studies, and we could see the activation increased a lot, and also the amount of movement, but not according to the targets. And this is why we went with our research more in this direction, to really get targeted therapy. And this up to now still requires all this like more accurate technology. But of course, it's great to always cooperate.
Can I put a link on the thing?
Great. Yeah, great.
Maybe Jenny Carroll wants to comment as well.
Mina.
Yeah, just going back and asking the question around the supervision that you asked before, and I guess it's going back a little bit to what Lorenz was saying. It goes to your analysis as a clinician of what it is you're trying to achieve with it, and then hopefully you can set it in place and set it up so that it works on its own, and people would need to come back for, you know, how do we move on? What's the next thing to do? What are we now trying to achieve? And it's balancing that with keeping the fun element, because I think that's a really, really important part of what you're doing, because, you know, play is the way children learn, isn't it? It's their occupation. But yeah, I think you would want to supervise it on a regular kind of basis, and that would vary from child to child. Exciting work, thank you.
Thank you, Jenny. Mina?
Yeah, my comment actually was going in the same direction, and I think Lorenz stressed already with the last slide that the play element is important, and the more therapeutic supervision you have, the more the child or adolescent feels that something is wrong and that there's again a health professional saying, oh, you have to do this. So the idea is to play and just let the person then indeed play and trust child and family, I would say.
So our experience from the study was that there is quite some supervision needed in correlation with the severity of the disability, but it does not need to be a therapist all the time. So there is close supervision by parents needed, and it's enough if there is a therapist correcting once or twice a week. So this was our first experience.
Encouraging impressions. Okay, I think we're in time at the end. Rainer, do you want to close this?
I just want to take over. So thanks to everybody for sharing this first actually German session in this format. We hope that we are even more successful next years. It was just the first trial, and I think it was quite successful. I think it was a useful experience, and I want to now to announce once more, I think our next conference, as you all know, that we are organizing the Congress 2025 of the don't know. Do you see that?
We see your
I can
screen.
see it.
Yes.
I can't see it actually. So I don't know. There's still the pitch 3 with Serious Gaming on my.
Just go down, or I do it.
Yeah, so you just should show it actually for me. So so
Okay,
that's
was quick.
it's a bit short. And then, so anyway, I just want to advertise a bit for 2025. There's a long time to go, but thanks everybody for sharing your ideas and for taking part of this session. Thanks a lot. See you then.
Bye-bye.
Bye-bye. Macht's gut.
Thank you. Thank
Very
you,
much.
Sebastian. Thank you. Thank you, Lawrence.